we will open this for everybody to opine before we wrap up. So this is in a friendly atmosphere. There's no challenging. It is more to learn gradually, and by dint of repeated meetings like this, we hope that the entire community will be educated, learning from others and learning from experts in the field. We also have a system by which we record this and the meeting and circulate it with some discussions and journal roundups for everybody to, self-improve if they are interested, and I assume they are, in the field of vertigo. We are waiting for Dr. Alfargal. The moment he comes in, I'm going to invite Niranjan. Niranjan is the man behind Cyclops MedTech. He is both entrepreneur and a amateur scientist, extremely knowledgeable in the field of vertigo. And let me start now because I see Dr. Alfargal has come in. Dr. Alfargal, Salam Alaikum. Greetings from India. Dr. Alfargal, can you hear me? Hello? Hello? I see a fair sprinkling of people who appear to be outside India. May Elbar, could you just tell us which country you're from?
Hi, could you hear me well?
Yeah.
Yeah, I'm from Canada. I'm a PhD student here in Canada.
Oh, great, great. So does that mean you speak French or you're an Anglophone?
English.
English, okay.
We are in French Montreal. It's common here in English.
Okay,
Other
great.
states French.
Okay, great. And Bart, where are you from?
I'm from
Hello,
Egypt.
I'm from the Netherlands.
Okay. So I don't speak Dutch, so I don't know Dutch, but great to have you on board. Okay, so I think we're still having problems getting...
Yeah, I think Professor Alfargal just messaged. He's deliberately on mute because it's their Ramadan iftari time. So he's able to hear us, but he will unmute in the next 3-4 minutes. So by then, I think I'll just do a quick welcome. Good evening, everyone here in India, and good morning, good afternoon for others who have joined from around the world. Thank you, Dr. Nair, for the kind introduction. I mean, sincerely, I'm not half as much as he's told. So yeah, like he mentioned, I'm the CEO at Cyclops, and basically I take care of the overall day-to-day running of the organization, and also strategy and partnerships. And very happy to tell everyone that this is the 25th edition of the Vertigo Grand Rounds, which is a landmark event. We've been successfully running this for the last close to 2 years. And I would like to sincerely express my gratitude and thank everyone who've been vehemently supporting this event over the last couple of years. We have great plans to actually make this an even more utility-driven and more successful event in the coming days. There will be a few measures that we are going to take. I'm sure some of you all might already be aware that starting, I think, from the last month, we have been sending synopsis of the event in the form of a newsletter on a monthly basis. Now, this will continue. The newsletter itself is being made a very elaborate effort in addition to complete case review of the case that gets discussed in the VGR. We are also doing a lot of journal scan and sharing a lot of insightful articles and so on. So that will grow and become even more value driven. And as far as this edition of Vertigo Grand Rounds is concerned, I would like to extend a very warm welcome to Professor Alfargal, who needs no introduction. He's a luminary in the space and globally renowned audiovestibular scientist. And he's kindly consented to be the expert panelist to discuss the case this evening. And I would also like to extend a very warm welcome to Chandrakanta Jain, madam. We all know that she's kind of educating a lot of us on Facebook constantly by sharing very insightful videos of eye movements. And I think probably today she might have one of the largest collection of eye movement videos in India. So thank you, madam, for consenting to present this important case today. So, and I would like to extend a very warm welcome to everybody who's gathered here today. Hope we have a great presentation and follow-on discussion. This is the 25th edition of the VGR. We hope to see many more months of successful running of the event. I mean, for a lot of people, come Friday evening, it is time for VGR. So we would like that mindset to continue. So thanks, everyone. And let's start off.
Yeah. So thank you, Niranjan. So without any further ado, let us first briefly introduce Chandrakanta Jain, who is a very well qualified audiologist who has experience with computers. She is qualified in computer applications. So she's a scientist and an audiologist. And with her husband, they run a hugely successful clinic in the northern western region of India called Rajasthan. The romantic, poetic cities of Rajasthan, very much part of the folklore and history of India. And we look forward to her presentation. She will be talking about two cases. Basically, her presentation would focus on eye movements in semicircular canal disorders. And I invite her to take the stage and take the mic.
Okay. Thank you, sir. A very good evening to Professor Mohammed, Dr. Ravi Nayar, sir, and all the participants who have joined the webinar. Thank you for grateful introduction, sir. And thanks to whole Cyclops teams for giving me opportunity to present my cases on this platform. Sir, I am audible, sir?
Yes, I can hear you.
Yes, sir. Today I am presenting
Hello?
two cases.
Can you hear me
Share
now?
your screen now.
Oh, yes. Is that Dr. Alfargal?
Can you hear me now?
Yes,
Yes,
we
sir.
can you, but we can't see you. I can hear you, but I can't see you. Dr. Alfargal, I'm going to use the standard line, needs no introduction.
No problem. No need just to go on.
No. So
Just
there's a
wanted
long
to be sure
introduction, which
you can hear me.
I would
Sir,
love to. We've already.
Good evening, Professor Mohammed. Good evening, very good evening, sir.
Good evening. How are you? Nice
Fine,
to be
fine.
with you today. All the
Yes,
best
sir.
in your grand rounds.
So
Okay, sir. Thank you.
let's start, Dr. Chandrakanta. Please start with the case. And
Today I am presenting two cases of posterior canal BPPV. One is right posterior canal BPPV and second is left posterior canal BPPV. And also showing eye movement in both type of cases and VNG tracings and graphical view of VNG.
Go ahead.
This is our EHT hospital situated at Bhilwara in Rajasthan, India, near the Ajmer city. My husband, Dr. Rajesh Jain, is a cochlear implant surgeon, and we both are giving all ENT services under one roof. BPPV. As we all know, benign paroxysmal positional vertigo Benign paroxysmal positional vertigo is most common episodic vestibular syndrome. BPPV develop when calcium carbonate particles, which we say otoconia or air dust, are part of utricle, moves into semicircular canals and make them sensitive to gravity. Most common characteristics of BPPV are BPPV is almost always triggered by change in head position. People may feel vertigo when they lie down, sitting up in bed, and when they tilt their head back or side to side. This vertigo sensation can range from mild to severe, and duration of vertigo attack is less than 1 minute. Nausea and vomiting may associated with vertigo episode. Nystagmus beats are present in crescendo-decrescendo pattern. A reversal of nystagmus is present in mostly BPPV cases. Risk factor of BPPV are age, vitamin D deficiency, osteoporosis, migraine, head trauma, hypertension, diabetes, stroke, smoking, drinking, and most cases are idiopathic. Type of BPPV. Otoconia present in utricle and on otolithic membrane. When these otoliths enter into semicircular canals, they make them sensitive to gravity. When otoconia present in anterior canal, they create anterior canal BPPV. When otoconia present in lateral canal, in the anterior arm of lateral canal near the cupula or on the cupula, they create the apogeotropic lateral canal BPPV. When otoconia present in the posterior arm of the lateral canal, they create geotropic lateral canal BPPV. And when these otoconia present in the ampullary arm of the posterior canal, they create typical posterior canal BPPV. And when these otoconia present near the common crust, non-ampullary arm of the posterior canal, they create atypical posterior canal BPPV. We see the posterior canal BPPV is more frequent. Why posterior canal BPPV is more frequent or more common? Otoconia can enter in any canal, but posterior canal is most frequently affected due to its anatomical alignment. Otoconia gravitate to posterior canal easily because it is the most gravity-dependent part of vestibular labyrinth in both upright and supine position. How to diagnose and treat the BPPV? The BPPV is diagnosed by the positional testings. By positional testings, we search the location of otolith. In this picture, we can see the otoconia are present in the different canals. And how to treat the BPPV? By appropriate manure, repositioning manure, we send them again back to the utricle. And in this picture, we can see all these otoliths are present in center. These otoliths are repositioned by the repositioning manure and they sent to their house, which is utricle. Approaches to the positional triggered vertigo. Posterior canal BPPV is diagnosed by the Dix-Hallpike test and the nystagmus pattern is torsional updating. The repositioning manure for posterior canal BPPV are Iple manure, Simont manure, and quick liberatory rotation. Geotropic lateral canal BPPV is diagnosed by the supine head roll test and nystagmus pattern are horizontal nystagmus beating toward the ground in case of geotropic lateral canal. And the manure are Buffoni manure, barbecue roll, modified Jumba manure. Apogeotropic lateral canal BPPV diagnosed by again supine head roll test and the nystagmus are horizontal but beating away from the ground. And the manures are modified Buffoni and Jumba manure. Anterior canal BPPV diagnosed by the supine straight head extension, torsional down pitting is the nystagmus pattern and Yakubina manure is repositioning manure. How to perform Dix-Hallpike test? I am showing fully supported Dix-Hallpike test. This is fully supported because I use a pillow beside the patient.
Um, May I suggest you come to your case early so we can have Dr. Alfargal do a detailed discussion of the case?
Okay, sir.
Yeah.
This is fully supported, and this is the traditional Dix-Hole-Pike test. In traditional Dix-Hole-Pike test, to turn the head 45 degree to right and lay down in supine position with head extended 30 degree beyond the edge of couch. At this time, the otolith move from here to here, and this is according to evolved third law. Posterior and superior canal ampulofugal flow causes the excitatory response, and ampuloputal flow causes inhibitory response. At this time, this is the ampulofugal endolymphatic flow, and it creates the excitatory it make the posterior canal in excited. I am presenting my first case. A male patient, 45-year-old, had complained of positional vertigo for last 2 to 3 days. No other pathology he had. First time he had positional vertigo. He felt vertigo when lying down and sitting from bed. He also felt vertigo in lean and bow position. In VNG testing, no spontaneous nystagmus, no gaze evoked nystagmus. All oculomotor test was normal. In positional test, I found in right Dixolpike head extended, upbeating and anti-clockwise nystagmus, and sitting from right Dixolpike, I found downbeating and clockwise nystagmus. This patient is diagnosed as posterior canal BPPV, right side posterior canal BPPV, and patient recovered by IPLE for right posterior canal BPPV. No nystagmus and vertigo symptoms present in retest of positional testings. I am showing the video of that patient's recording. We can appreciate anti-clockwise and upbeat nystagmus. VNG recording of right Dixolpike of that patient. Again, we see upbeating and anti-clockwise nystagmus. You appreciate all?
Yeah, go ahead.
Anti-clockwise on the right Dixolpike head extended position. I skip this. VNG tracing of right Dixolpike head extended position. In the VNG tracing, this is for right eye and this is for left eye. In the red and blue line, we are seeing the horizontal, in the eye movement in the horizontal axis, and the black and the purple line show the vertical movement of the eyes. We can clearly see upbeating nystagmus. Fast phase is toward the upside and slow phase is toward the downside. In the graphical view, we can see the value of slow phase velocity value of left and the right eye. The right eye have more vertical component than the left eye have the more vertical component than right eye. Why the left eye have more vertical component and right eye have more torsional component we will see in a few slides. VNG recording of sitting from the right Dixolpike. When I sit that patient, I found downbeat clockwise nystagmus. We can see downbeat and clockwise. And the VNG tracing of sitting from right Dixolpike position. In this line, we can see this graph, we can see downbeat nystagmus, fast phase toward the downside and slow phase toward the upside. We can clearly see both in both eye pattern, downbeat, and downbeat. And the slow phase velocity are right eye and left eye. Left eye have again more vertical component. To understand the movement of the eye in Dix-Hallpike test, first understand the extraocular muscles and their primary functions. We have four rectus muscles and two oblique muscles. Four rectus, superior rectus, inferior rectus, lateral and medial rectus. Superior oblique and inferior oblique muscle. The primary function and only function of the medial rectus is the adduction. Lateral rectus, the primary and only function is abduction. I move outward. In this, I move inward. Inferior rectus muscles, primary is depression and extrusion and adduction. Superior rectus muscles, primary function is elevation, secondary intorsion, and tertiary is adduction. Inferior oblique muscles, primary function is extorsion, secondary is elevation, and tertiary is abduction. Superior oblique muscle, primary is intorsion, secondary depression, and tertiary abduction.
Maybe you could go back to your case, because we'll have explanation done by Alfredo.
Yes, sir.
Yeah.
Medial rectus, yes, sir.
You have another case, I think.
Yes, sir. I have one more case, sir.
Please, why don't you share that?
Yes, sir. Sir, I skip all these slides.
Yeah, I think you may, because in the interest of time, and to ensure
Okay,
that
sir.
Dr.
Yeah,
Alfredo
yes, sir. Definitely, sir.
millions of years of experience. We'd love to hear it.
After recovery, the patient send me thanks message, and when we they send us thanks message, we feel proud and happy. I skip also this. My second case is a 50-year-old female feeling positional vertigo since last 4-5 days. She underwent hysterectomy surgery before 20 days and she was in rest period. She was feeling vertigo on all position in bed, sitting from bed, but more severe on left side. In VNG testing, no abnormality found in oculomotor test, no spontaneous and no gaze evoked nystagmus. In positional testing, I found upbeating clockwise nystagmus in 3 positions: left supine, left distal pike, right distal pike. Patient was also symptomatic in all 3 positions. In right distal pike, upbeating clockwise nystagmus was very few, but vertigo sensation was very severe. One thing should remember that nystagmus pattern would decide the type and side of BPPV. Note the positional test and side on which we get. In this patient, I get upbeat clockwise nystagmus in supine roll test also and in right distal pike also, but the torsional component is clockwise. That's why the affected side is the left posterior canal. According to nystagmus pattern, it was left posterior canal BPPV. Patient was recovered by Iple maneuver for left side. I am showing recording of that patient. On left distal pike head extended position, I found clockwise upbeating nystagmus. Unfortunately, I could not find video of right distal pike and left supine position, but I remember that patient was fully symptomatic and have same upbeating clockwise nystagmus in all 3 positions. VNG recording of left distal pike head extended position, I am showing of that patient. Again, we can appreciate torsional, clockwise torsional and upbeating nystagmus. Again, left I have more torsional component and right I have more vertical component in case of left posterior canal BPPV. The VNG tracing of that patient, we can see upbeat nystagmus. In this also upbeat nystagmus, but the right I have more vertical nystagmus, and in the graphical view we can see the left I have more vertical component comparatively the right eye. Now, when I sit back patient, I found downbeat and anti-clockwise nystagmus. The reversal of nystagmus. In head extended position, I found upbeating clockwise nystagmus, and when patient sit back, I found downbeat anti-clockwise nystagmus. And the VNG tracing of sitting from left distal pike head extended position, we can see downbeat in both eyes. And in the graphical view, we can also see the downbeating slow phase velocity toward the right, and fast phase is toward the downside. And vertical value is the right eye have more vertical value and the left eye have more torsional. We can see in the video. Why posterior canal in posterior canal BPP? Why we get upbeat anti-clockwise nystagmus in the head extended position, and why we get downbeat anti-clockwise nystagmus in sitting from left distal pipe? Because when we lay down the patient in head extended position, that time the left posterior canal excited in excited position, and the excitatory projection of the left posterior canal are ipsilateral superior oblique and ipsilateral uh, inferior rectus. The superior oblique and inferior rectus muscles move the eyes slowly anti-clockwise and downward. Again, a corrective saccade is made that move the eyes fastly upward and clockwise. That's why we see clockwise updating nystagmus. Again, when patient sit back, otolith move toward the cupula, and that is the inhibitory phase of posterior canal. And in that time, in that position, the inhibitory projections of posterior canal are ipsilateral, inferior oblique, and contralateral superior rectus muscle. The inferior oblique muscle and superior rectus muscle move the eyes slowly upward and anti-clockwise and clockwise. Again, a corrective saccade is made, eyes move downward and anti-clockwise. That's why when sitting up from left pixel pike, we get downbeat anti-clockwise nystagmus. Repositioning maneuver for posterior canal BPPVR, Iple maneuver, cement maneuver, and quick liberatory rotation. I describe briefly. We can see the otolith journey during the Iple maneuver. At this position, otolith are near the ampulla. When patient lay down in first position of Iple, otolith move away from the cupula. At this position, otolith move toward the common crust. At this position, otolith arrived at the common crust, and when patient sitting back, it throw out to the utricle. Simont maneuver. I am showing a video of Simont maneuver. Patient should move fastly from position 2 to position 3. From position 2 to position 3, we have to move the patient within 1 second. At this position, otolith move by the gravitational force, and at this position, otolith move by the inertia force. Quick liberatory rotation is similar to the play in the sequence of position of the head in the horizontal plane, but it is more like the Simont maneuver in the speed of the movement. I am showing a video. This is the first position of play in the quick liberatory rotation. head extended 30 degrees beyond the edge of couch. We appreciate nystagmus, upbeat and anti-clockwise on right side. Now I have to move the patient. This is for left posterior canal. Patient have to move from this position to this position within 1 second, and we skip this position. This rotation is near about 180 degree. Key home messages are nystagmus pattern will decide the which canal and which side is affected. Torsional component will decide the affected side in case of posterior canal. If updating anti-clockwise nystagmus, then right posterior canal BPPV. And if updating clockwise nystagmus, then the left posterior canal BPP. Even we get clockwise nystagmus updating clockwise in supine roll test or right disc hole pike, but the canal affected is the posterior canal. Torsional updating nystagmus can be elicited during the supine roll test. Thank you all for careful listening, and special thanks
Thank
to
you very
Professor
much,
Mohammed and Anirben Viswas sir, Professor Lugi Califano, Dr. Srinivas sir, Dr. Maza, Dr. Vishal Pawar, Dr. Andrea, Dr. Ajay Vas, Dr. Iona Voda, and my husband, Dr. Rajesh. Because from all these, I have always learned directly, indirectly, and their work always keep me motivated. Thank you, sir.
Thank you very much. I think I'm sorry I had to apply some
Yeah.
push to make you do it, but I think
No,
that
no,
was
no, sir.
fantastic.
I also want to hear Professor Mohammed. It's very
Yeah,
great
so no,
for me.
that was fantastic, and we're really grateful to you for giving us a quick overview, not only of the patient, its presentation, and your treatment, and how you do it. So that was fantastic, and I think we're all grateful to you. So let's have Dr. Alfargal on screen. I think everybody is eagerly waiting to see you. Dr. Alfargal, are you there? So,
Unmute. Yeah, you
yeah,
be able to
great.
hear me right now, right?
So, Ramadan Kareem to
Hello?
you. And can you hear us?
Yeah, I hear you well. Do you
So,
hear me?
Ramadan Kareem to you.
Thank you. Thank you, dear friend. Thank
So
you, Ms. Chandra, for your beautiful and enthusiastic presentation and work. And it's
Thank
my
you, sir.
great pleasure and honor to be here with you today.
Sir, I am
So-
also very grateful, sir. Thank you,
So,
sir.
so to get the ball rolling, Dr. Alfargal, in the process of the last couple of years, there's been so much of literature on other canals, different types of canal issues in BPPV. Do you feel that we could have missed a lot of cases in the initial diagnostic workup?
That's correct. There is evolving literature, and simply like if you think about the prevalence of lateral canal BBV, it was thought that to be maximum 15% just a few years ago. But right now, with the new literature, it was reported even up to 40%. And we didn't know much about complex forms of BBV, like multiple canal BBV, which I published a little bit about it, and also like atypical or apogeotropic variants of posterior canal, and we are learning. So I have few thoughts to share today. We have alphabetical for vestibular practice. Those alphabetical rules are the Ewald's law. And these Ewald's law, sometimes in the literature, they are like 3, but also I think they are 4, not 3. So the first law is because those are the key information and the milestones for any practice. If you can understand and you can apply in your daily practice, your work with BBV will become a pleasure, will become a fun, you will enjoy. So first law that each canal will generate slow eye movement in the plane of that canal. So generate like posterior canal generate upbeating torsional nystagmus because it's very specific to each canal. Second law mentioned by Ms. Chandra, that is ambulopetal flow, ambulopetal endolymphatic flow in the lateral canal is excitatory, but ambulopetal endolymphatic flow in the vertical canals, it's inhibitory. And ambulofugal is inhibitory in the lateral canal, but it is excitatory in the posterior, in the vertical canals. So those are sometimes like second or second and third law. But there is one important law which explains many findings discussed by Ms. Chandra today in her presentation, which is the fact that is the semicircular canals, they respond more for excitatory stimuli than for the inhibitory stimuli. And that explains why always in the videos and in practice, you will find that is the excitatory response is much more stronger than the inhibitory response. So the pattern of nystagmus, duration of nystagmus, strength of nystagmus, it really depends if that stimulus is excitatory or inhibitory. And this is explains many phenomena which we didn't know before in BBV. Like if the semicircular canals, they are semicircular. So the otoconia can be placed along this curve. And if it's ambulary or non-ambulary, so when we position in a certain position like the Dixwell bike, if like mentioned by Ms. Chandra in her presentation, and will explain that if the otoconia in the ambulary arm of the posterior canal, so when you place in the Dixwell bike test, it will generate ambuloflugal endolymphatic flow, which is excitatory. That's why it generates the typical nystagmus. But if the initial placement of this otoconia in the non-ambulary arm near to the common cross, really it when it's placed in the Dixwell bike test, by the effect of gravity, it will generate ambulopetal endolymphatic flow, which is inhibitory. That's why it gives the typical downbeating nystagmus of apogeutropic or what's called a typical posterior canal BBV. So by mastering this alphabetical rules or alphabetical language in the vestibular practice, you can analyze the eye movements and you can understand what's going on in the semicircular canals. And even you can use these rules to know if you are doing a successful maneuver or no. For example, I have a patient with posterior canal BBV. It shows typical beating torsional nystagmus in the Dixwell bike test. So I decided to do a canal repositioning maneuver. So when I'm moving to enable maneuver to the second step, which is 90 degrees towards the healthy side, the generated nystagmus will tell you if my maneuver will work or not. I can know from beginning. So if it gives you upbeating torsional nystagmus, that means it's ambulofugal. The debris is moving out from the posterior canal. So I know I'm moving in the right direction. But it gives me reversed nystagmus, which is inhibitory. It gives me downbeating and become reversed. That means it's going back to toward the ambula, and it will not get clear. That wouldn't be a successful maneuver. So I can monitor also using especially if I have a video nystagmography or I'm doing the repositioning under monitor of video goggles. That's really very helpful. I can know if the maneuver will work or not. I can know if it's successful or not. Just the idea, this is where we have to really to enhance our knowledge and try to completely understand and digest and try to analyze this pattern of eye movement, because this will explain everything for you with confidence. If you want to comment, I can stop and
Yeah,
ask
so
me something else.
no, I'll keep. I know. We'd love to hear you So I just
Okay.
like to keep you moving. Let me ask you another additional question. Have you
Yes.
ever had to have a differential diagnosis in BPTV? Are there conditions you would feel are often mimicking it?
Yeah, sure. There is differential diagnosis for all the conditions. It is starting from the history. If it starts like the patient came to you, when I move my head, I feel dizzy. So actually, does not mean BPV. It could be vestibular paroxysmia. It could be uncompensated unilateral hypofunction. Sometimes it happens with vertebral artery torsion. If they just do torsion movement of the neck and twisting of the vertebral artery, some exceptionally vulnerable individuals, this could trigger the symptoms. Vestibular paroxysma due to vascular compression loop or due to another reason. That's its usual presentation is transient vertigo triggered by head movements. And the main thing, and this is where the confusion in practice coming, that is in all causes of vertigo and dizziness. Vertigo get worse in the Dixwell bike test. Vertigo get worse with head movements. So actually, and this is the problem, like in ER physicians or people who are not adequately trained, they ask the patient direct question. If you move your head like this, or do your dizziness become worse now? It become worse or it is the same? So the patient will become worse. Okay, that's BBV. So number one, all vertigo, all dizziness get worse with head movements and with positioning. All kind of vertigo and vestibular dizziness could get worse. But the main difference, if it's either only triggered, directly triggered in this position, or just it get worse. Second, that is there is conditions which could really cause vertigo with head movement, like vestibular paroxysm, and also with positions. Sometimes perilymphatic fistula also, it will show in the positions because you are changing the gravity alignment. And this is a change all the pressure mechanisms. This is something. Also central positional and central positional vertigo and central positional nystagmus. That's it could happen because in positioning, what we change the alignment to the gravity, the effect of the otoliths and the effect of the different pathways. So you are putting sometimes it just reveal with these positions, and that's why we have some criteria to be able to differentiate peripheral from central positional vertigo. And yes, there is latency. All textbooks, everyone knows about this one. With peripheral, there is somewhat some few seconds of latency. In central, there is immediate start of the nystagmus. The duration, most of the BBV nystagmus is transient, and it lasts, yes, in majority less than 1 minute, but in exceptional cases, sometimes it lasts even up to 2-4 minutes. So sometimes we are not so rigid. In my clinic, if I want to say this nystagmus is persistent, I use the 4-minute criteria. And sometimes we have the patient just to wait, because if you have, and this criterion was put by Professor Giacinto Asperilla Libonati, not myself, and I like it, and we use it in our clinic. So by confidence, if you have any kind of positional nystagmus which lasts more than 4 minutes, yes, with confidence, I can say this is something persistent. And the more important, what is the most important factor or way to differentiate peripheral from central positional vertigo and nystagmus is the response to repositioning maneuver. Response to repositioning maneuver. I do expect that is nystagmus from the BBV will clear after repositioning. Yes, fatigability is there if you repeat. That's why I saw in the presentation of Ms. Chandra that she do clinical exam first, then she do with the VNG. In my clinic, we do immediately with the VNG, because if you repeat the testing, this is sometimes causes fatigability of the nystagmus. So you see less clear nystagmus. Second, sometimes it changes the location of the otoconia. So that's why if the history is subjective of BBV, I don't do the clinical and just look to I put directly to the video goggles or the VNG, and we do the testing, and we see it more clear. So those are the differential diagnosis of head movement induced vertigo, position induced vertigo, and position triggered nystagmus or something. So we have to be careful. One important point, this is, I feel I have to say and have to stress that point. We have to be very gentle, very careful when we examine elderly. BBV is much more common in elderly. It is 7 times more common in elderly than the younger population. And those elderly people, they have osteoporosis, they have atherosclerosis, they have a lot of medical issues, and they are very fragile. And that's why handling, manipulating, it should be very gentle. And the technique presented by Ms. Chandra, that you put a pillow, it's actually what triggers the symptoms in the Dixon bike is the orientation to gravity, not extending the neck or do. So if you do it in a way to orient the semicircular canal with the gravity, you are doing the right position. So why we put the pillows? This is to, instead of doing extensive extension to the neck, so I divide it. So I do extension for the back by putting the pillow. This is will give me like 20, 30 degrees of extension to the back with the neck. Then again, I do little. So I will be in less need to do less extension of the neck, because this is the worst movement you can do. And this is if you have a patient with recent stroke, if you have a patient with non-vertebropatellar insufficiency, with hypoplastic vertebral arteries, with cervical spine instability, you have really to be gentle and to be cautious. And the worst is to do extensive head extension in elderly people. That's usually we try to avoid. And yes, as she mentioned, fully supported. Yes, always support the neck. And we teach all our staff that really you have to be concentrating, holding very well, controlling the patient. And because sometimes the patients, they react when they have the intense vertigo. So that's why you have to be controlling, alert, and really protecting the patient. And during the examination, during the treatment, safety and protection of the patient is the responsibility of the clinician. And in our clinic, all our staff, physical therapists, audiologists, and physicians, all our staff, they never to leave their hands from the head of the patient from start of the examination until the end, and until 2-3 minutes, even after the repositioning. Because sometimes after the repositioning, they have what's called utricular crisis. When the otoconia comes back directly to the utricle, it causes too much otolith stimulation. So they feel that they are falling down, and it's a good sign usually, but it happens like 10-20% of the cases. And you have to be holding the patient, otherwise they could fall. So always safety, protection of the patient, gentle, be very gentle. Practice more in younger, healthy people, colleagues. So that's why you gain the confidence, because also we observe it that if with junior staff, if they are little irritable, anxious, the examiner, they tend to be little rough while handling the patient. So giving them adequate training and adequate practice to be comfortable, controlling, so they can be in charge for examining and treating patients with BBV.
So, I'm just keeping you talking. We enjoy listening to you talk. So I'm just going to keep probing you for talks. So I have one more question
Sure.
after throw it open to the house. Do you have any particular preference for doing Simons or Epleys?
Good question.
Make a choice.
Thank you. I do all the maneuvers. We do also modified maneuvers. The idea that is you get a proper training. And usually that's really to be trained practically on site with a supervisor. For me, when I wanted to learn Simont maneuver, I went to the two first students of Simont. I couldn't go to Simon himself. He's still alive, by the way. But I didn't reach him out, but I reached to his two first students. And they taught me individually, hand by hand, and repeated many times. Because honestly, for Simon maneuver, it's very well known in France. They got perfect results with it in France and Europe, especially in France. They prefer Simont, and they got marvelous result with it just because they do it in the proper technique. There is an issue about learning from the YouTube, learning from the textbooks. It's never really addressed, and there is always there is secrets for everything. There is tips for everything. So I hope when coming to India or somewhere, I can share with you how we do Simont maneuver, because it's one of my favorite maneuvers actually in the clinic. We do like half of the patient Simon, we do half of the patient Ibli. Yes, if I have, like yesterday, I think, or 2 days ago, I have a patient who's 200 kilograms. 200 kilograms, and he has PPV, and we have to do repositioning. That's a big challenge. And for that heavy patient, really, we choose Ibli maneuver, because it's very hard to do the Simont in the right way with this weight. But some people who have really like back issue, some cervical issue, sometimes we do the Simont maneuver, and there is two modifications for the Simont maneuver. One is Simont Plus by Stroop, but honestly, I don't do the Simont Plus, and I don't believe it gives any additional benefit. That is doing more extension of the neck. And there is what's called the Lee maneuver. This is a Korean professor, and what he do less extension of the neck. So his modification is very safe for the patient with cervical spine issues and elderly, very elderly. I told we try not to manipulate hard, not to twist the neck, and some of those with significant cervical pain, we do the Lee modification. I give you the secret. Honestly, it's one secret, and this is how we teach our train in our clinic. Look to the pinna of your ear, the pinna. This one, this back half of the pinna. This is actually represents the posterior canal. So if you want to do a good maneuver for testing Dixel bike, get sure that pinna is become down. So if you do, and that posterior half of the pinna become this semicircular part become with the gravity become down. So that's a good testing of the posterior canal BBV and nystagmus will show up. And in all maneuvers, it's a rule how we do repositioning. We move from the affected side towards the healthy side in steps. So your rule in treatment is to, after provoking the nystagmus in the diagnostic maneuver, either Dixholbaic or side-lying maneuver, get sure that spinna is downward completely. So the autocorneal precipitate. So in the coming movements, your role to bring this one completely flip it up. So in the third step of the Ibli maneuver, or in the third step of the Simont maneuver, this one has to be up. Just flip it so that the autocornea will go outside. So we use it as an indicator. And in my clinic, all our staff, they got trained. This is the way. Make it a good indicator, because everyone has a pinna, and it has all the same representation of the plane of the posterior canal. So they use this guide. We can get it by side lying, we can get it by the Dixol bike. And during repositioning, this one, when bring it from downmost to the uppermost. So this is the trick. This is the trick. You have, if you succeeded to this one, most likely your maneuver will be working. So Unfortunately, most of like textbooks, everything, they take things slightly. And I see people, even the patients themselves, they watch on YouTube, they start treating their relatives or treating themselves and doing. And that's why I always got migration to other canal, diversion, spreading of this otoconia to all the semicircular canals. So sometimes they got worse, but sometimes by chance they got better. And people, even patients, they started from the tube. So I am against this kind of taking it lightly, because anything related to the human health or the health of our patient is something serious. We have to have a good, proper education. We have to have a good and proper training from competent tutors. That's very, very important. It's a profession. So in all the professions, you have senior people, and you have junior people, and when they get trained in the right way, I can tell you, in our very, very busy clinic at National Guard Hospital in Jeddah, we see very huge number of these patients. I rarely do the repositioning myself. From our team, from audiologists, physical therapists, they are the one most of the time they do, but they don't do unless they become perfect. And how they become perfect? Supervised practical training. We don't let them do alone until really they spend a deal of time, like 6 months, 1 year, under our supervision, and following these rules: safety, control of the patient, protection of the patient, being very gentle, being alert, being confident, doing it. But once you learn it, really you become. What's happened? People, they read, show the picture, do like this, do like this, it work. And sometimes it work, especially young, healthy patients. Sometimes it work. This is encouraged, that just do, keep doing. But this is not the best way for practice. Proper training, and you have to really to have the knowledge which make your practice insightful. So I mentioned about Ewell's law. I give you that rule for the posterior canal, the philosophy of all the repositioning maneuver to move from the affected side to the healthy side. And you use the gravity, or can use the inertia. Seamonti maneuver is a wonderful, but the idea is that many parties in the world, they don't have the chance to have proper training how to do it. That's why Eble maneuver is more common, and it works very well. And there is modifications, and sometimes even we do our own modifications because we know what we want to do. So if I want to provoke nystagmus, I want to align that canal with the gravity vector, so the otoconia will move and trigger. I want to treat, so I know I want to move this otoconia from here. Then I have a monitor. I can do repositioning under monitor, and this is something I encourage everyone, do the repositioning under monitor, because you know that maneuver will work or no by just monitoring the direction of movement of the otoconia. So it's like if you do ultrasound guided biopsy, or but you can also do video nystagmography guided repositioning. So you can use the monitor, so you know it worked and it will. And sometimes it's easy to recognize it doesn't work, so we prepare our patients that we do again.
So I have, I'm sorry, I'm going to really exhaust your saliva.
No, I'm fine. And now I can break my fast, so feel free. And I like to talk, so no problem.
Okay, so we like to listen, so that's a good combination. So, so two questions. Do you use any vibratory devices along with procedures?
Good question. Skull vibration is part of our routine clinic, and we have tens of vibrators, but lately we got one. I sent those Nerinjan one to your office. You can see this is a very good vibrator. We use it for skull vibration test, which is a very, very sensitive vestibular test, and I'm sure it gain popularity, and more popularity in the coming few years. For BBV, our protocol we do the repositioning. We never do once, a minimum we do twice. So the minimum is to do twice of repositioning, because sometimes first times the patient is not familiar, he is resisting, we are not sure. And there is some evidence in the literature that increasing the number of repositioning trials that improves the outcome. So always we do more than one repositioning, sometimes 5 minutes, 10 minutes apart. And sometimes also, if it didn't work, we keep doing like up to 3 and sometimes even 4 repositioning, as if the patient doesn't have nausea or vomiting. To minimize the nausea and vomiting during the repositioning, always turn the EC cold. In our clinic, we turn it 16 degree. And if you don't have EC, just open a window for a fresh air, because cold temperature and fresh air decreases the nausea. So this is one. If then we follow up the patient like after 3 days, from 3 to 5 days, we follow them up. If it's cleared, it's fine. If it's persistent, sometimes we change the maneuver. In the first time we did Ibli maneuver, so the second time we try cement maneuver. And I find that sometimes cement maneuver is more effective in resistant cases, and in atypical cases, sometimes I feel, because it uses also the inertia. And this is the second backup to try to change the maneuver. Then if it didn't work, so the last time we do, yes, we use a skull vibration. We have different vibrators. And the way you do, sometimes you hold it in your hands, you put it, then you do in the initial Dixon bike, so trying to shake it to make it move with the gravity, if it's adherent to the wall or to the copula, just to move. Then also in the third position of Ibli maneuver, we apply when you flip the downmost ear to become the uppermost ear, you also apply the vibrator, trying to clear as much otoconia as possible. But be careful, please. There is contraindication for the use of vibrator. Number one, if your patient has intraocular lens for cataract, after cataract surgery and they have intraocular lens, using a skull vibrator for diagnosis treatment, it can dislodge that intraocular lens. And that's very common. And when you put the patient the VNG, easily you can recognize if he has eye surgery or no. And if he has intraocular lens, avoid to use the vibrator by any means. The other thing, if the patient has a retinal detachment or at risk of retinal detachment, that like very high myope or something, or like extensive eye surgeries with retinopathy or something, we really avoid to use vibrators. So it's like everything like this, we need to educate ourselves about its advantage, its use, its contraindication, its precautions. So also any kind of like even this shock waves by the TRV, it's same. It has some, and my colleagues, they reported that sometimes it lead to more otolith disruption from the otolith organs, and this otoconia get more and go to more canal. So it's something sometimes, if you have a force or something, it has some advantage when wisely used, but when extensively used or inappropriately used, that sometimes it causes harm. So we have also to be careful. There is no one size fits all, or there is no magic solutions in the medical and healthcare practice at all. Everything has positives and negatives, and that's why the role of the good clinicians, how to use these tools in the proper way. If you use everything wisely, you will be a master. So it's not being like biased towards a certain way or something. No, and I don't expect artificial intelligence will replace the good clinicians, because this ability to judge individually for each case and to consider this multi-factors and a lot of aspects in the same scenario, this is only Almighty God gave to human beings.
So I'm pushing you to your limit. You can raise your hand.
No. I can talk 7 hours if you can, if you can withstand, no problem.
One which I have, it may appear trivial. We keep talking about primary problem of BPPV, and we do mention that sometimes it is secondarily caused by other diseases.
Good. That's excellent question. Yeah.
In your experience, how often do these things recur because of the secondary? How often does it flip on the other ear because of the systemic issues?
Thank you, Dr. Ravi, for this excellent question. I kept it in the notes actually to comment because your diagnosis of BPV is not complete unless you really try to disclose any risk factors. Again, I can say that you will not find everything in the text box. And I tell you something, have like always keep eyes on some patterns. You keep eyes, you develop your own insight. This is something I did over the many years of practice. I respect my insight, and we keep watching somebody. Tell you something never to be clearly published in the literature. We have a very strong head and neck department in my facility, and they do a lot, thousands of thyroidectomy for cancer thyroid and cancer parathyroid, and simply all those with either involvement of the parathyroid glands or removal of parathyroid glands after thyroidectomy accidentally during the surgery, they develop very, very, very bad BPV. Despite most of them, they are young and they don't have known risk factors. So to become very clear, every patient, when you touch his parathyroid gland, most likely, I can tell you, they have a very high possibility to develop very strong and very severe benign paroxysmal positional vertigo because of the disturbance of the calcium metabolism. So this is something we learn it from the reality, and it's like in our practice, it's a fact. Another thing, just we observe it over years. Just wait, please. The battery is.
So
Yes. Sorry, I fixed the battery. Something else we observe it clearly in our hospital. That is, all the patient with a pacemaker, they commonly develop BPV on the right side. This is simply because the pacemaker is always on the left side. They cannot lie on the left side. They strictly keep on lying all the time on the right side to avoid any pain or discomfort. And that's become very clear. Those with the pacemakers, that they develop BPV in the other side. And also for cancer breast, when they have at risk of lymphedema, they are prevented from lying to the operated side to avoid the lymphedema. And that's why they strictly lie on the side. That's very commonly to develop. So we started these things. There is always a reason. So what are the reasons? Or risk factors. Number one, any change in the calcium and the mineral metabolism, osteoporosis, vitamin D deficiency, parathyroid gland disturbance, sometimes renal disturbances. So anything will work with the calcium metabolism. It can lead that this kind of otoconia to become dislodged. We observe it, and it was published also. There is some weak genetic predisposition. So in our series, we have many families where we treat the grandmother, mother, and the daughter. So we have some families, they have BPV, and there is some work about this strength of this links.
I think we lost you, sir. Your image is frozen. So to the audience, if there's any other questions you would like to post on the chat, feel free. I'm actually sorry that we can't tap into the expertise of all the great people sitting in the audience, including Dr. Califano, Dr. Vats, I see a lot of big names, both from India and abroad. So I'm hoping that we'll get Dr. Alfargal online so we can ask him a couple of more questions. Is Dr. Alfargal, can you hear me? Dr. Chandrakanta, do you have any questions which you would like to ask him?
Sir, I want a vibrator. Which frequency vibrator you use? And you said that you have 4 different type of vibrator. I want to know about all 4 type of vibrator.
Share all that with you after that. So the
Hello?
yeah, can we hear you, sir?
Yes, I am back.
Okay.
You have a question or anything?
We have 2 questions. We have people who are interested in the vibrators. We will get the information from you and diffuse it to everybody. That is one thing. I have a question as to what is the youngest age of BPP you have encountered?
I think like 10 years or something. Post-trauma, post-hit trauma, that's common. And I think you have a couple of cases where they do have complete transverse temporal bone fracture in one side and BBV on the other side. And believe me, in those two, I think 10, 11 years, both of them, the symptoms was worse because of the BBV, not because of the complete unilateral vestibular hypofunction. And once you do repositioning, they significantly their symptoms improve because the brain cannot habituate for BBV simply because it hit and escape, hit and escape. So he has a big enemy. The brain cannot deal because he doesn't have enough time to analyze or understand the enemy or the one who's striking and hitting and it disappears. But in acute unilateral vestibular hypofunction, the brain has the time and the resources to recognize the enemy, make plans to fix it and to control the symptoms and start the vestibular compensation. That's why the symptoms really of BPV is very severe. So that's the youngest age. I think we maybe 10 years or something. We have one child like 7 years or something, but there is a rule that is BPV typical one. Unless there is a head trauma or scenario or concussion or something, it's generally rare in children. So when you have PVV in a child, take it seriously. And I think that 7 years we ordered MRI and just to clear. So you have to be cautious that BPV is not common in children. And if you have like positional nystagmus in a child, take it more seriously. Investigate more because this is something not common. This is for that question.
We have a follow-up question from the audience.
Sure.
Dr. Chet has asked a question that in case of multiple canals, do you have any preference which canal you address first? And
yeah, that's a good question. We have, I think, one of the longest series of multiple canal BBV. And in our clinic, sometimes in one day, we see 2-3 cases. I can say simply treat the posterior canal first because the outcome of repositioning of the posterior canal is much better than all other canals. So you have almost a guaranteed outcome that part of the symptoms and it will become clear. And there is also people thinking that is always the posterior canal is the reservoir for the autoconia because it's the most dependent. But here, let me to share a hint for you. Ms. Chandra mentioned that is posterior canal is most common because of the dependent in the supine position. True. But imagine if someone, they lie in the prone position. They lie on their face, on their stomach. Which canal will become the most dependent? Actually, the anterior canal. So that should to be considered. It's a part of our practice to ask the patient how they sleep and on which side they sleep and how they do sleep. That's why people like even some big names, they mentioned anterior canal does not exist. They do exist. They do exist for the people practicing yoga, and they putting the head down and the feet up. They exist in the patient who lie in prone, because anterior canal will become the most dependent in the prone position. So we like to ask the patient about how they sleep and which side they do sleep. Again, tell me the question. I think
So I think
forget.
you said that you would start with the posterior
Yeah,
canal.
posterior canal. Why? Because that is outcome is guaranteed. Level A evidence for Ibli and Simon maneuver, so it's guaranteed. It's the reservoir for the other canals, and in most common combination of multiple canal to have mixed posterior and horizontal canal at the same side. So one more thing, be clever. In Egypt, they said you hit to pair this with one stone. So the same you can do after we treat the posterior canal. Suppose the patient has right mixed canal posterior and horizontal in the right side. So we do Ibli or Simont for the posterior canal and ask a patient go home, lie on the left side. This is what's called forced prolonged positioning maneuver. And it's an excellent maneuver. And I am sad that Miss Chandra didn't include in the maneuvers of the horizontal canal. It's excellent maneuver. Use the gravity peacefully, especially in elderly people, very nauseating people. Just ask them to lie on the healthy side for one night, over the night. Simple sleeping. Just lie, use the gravity. You are flipping the horizontal canal up and down. So just by doing posterior canal repositioning, combining it with forced prolonged positioning maneuver for the horizontal canal, usually we can clear both of them. But yes, over all these years of experiences, I can tell you in a simple, just try. Always when you find posterior canal BBV, treat it in any patient because you are reducing a very significant amount of his symptoms if you just treat, and the treatment is almost guaranteed. So that's my recommendation.
So now I think, Dr. Alfargal, we really troubled you and we're keeping you from your iftar meal.
No, fine. I am fine. I am
Really,
fine. I am up to your disposal. Whatever you want, I will do. So don't think I'm feeling good.
okay, so let me ask one question while we're drawing. What do you see as the future of vestibular science?
That's a great question, really. I tell you something. I was the chairperson in the IFOS conference, which is the largest NET conference in the world. It was hosted in Dubai the last year. And I was the actual leading chairperson for the equilibrium track. And we have big argument with the organizers, with the president of the conference, and like this, because they wanted to give a very small hole for the equilibrium, and that is some eminent neuro CI surgeons and oh, what's vertigo? Nobody attend. Who will go that vertigo? Nobody is like this. Then we have much argument, and I got some support by Professor Frey, the president of IFOS, because his wife is a well-known French vestibulogist and professor in vestibulology, and he supported my proposal, and we got the big hole. Then actually the hole was full during the IFOS. The hole was full during the IFOS, and I take photos and send to the organizers. Yes, when the people they find a good program, there is growing interest. And last EROC in Dubai, by spontaneously, they give us the big hole and they call it equilibrium tract, and it was fully packed during the equilibrium day. It was fully packed. And just last week, the Saudi Otolaryngology Society, they called me and asked me to be the chairperson for the equilibrium track in their conference for the coming years. And they call it equilibrium tract, and they make it a very important discipline of the otolaryngology, and they can know the growing interest. So globally, worldwide, there is a global increased interest of the vestibular science, vestibular medicine, and this is normal because dizziness is the second most common complaint in medicine after headache. So it's very common, and there is no one specialty which gives a proper training or adequate training. I always say dizziness and vestibular is a specialty for the interested, motivated clinician. And I have been a witness on the excellent learning journey from learning until excellency of Miss Chandra. I admire her determination. She has a decision to become perfect in vestibular practice and to become a specialist, competent specialist in vestibular practice. And she worked very hard and very seriously, and she has been determined and have been trying her best, her time, spending all the efforts, trying to master and to learn and using her passion really to very, very, very fastly grow. She is a role model in when you are a newcomer to the vestibular field, it takes just a few years and you can come and present and become a recognized speaker, and we'll be happy to listen to you. So there is global increased interest. There is more activities going everywhere in the world, in India, in Middle East, globally. There is more networking. There is more public awareness of the importance. There is more proper placement of vestibular professionals from whatever the background, from otolaryngology, audiology, neurology, physical practice, family medicine, or whatever. Actually, the real world needs much more trained people and professional in vestibular science to be able to help the dizzy patient. And this is where our Avisa activities, a lot of activities try to help just to make that education training affordable and feasible for everyone.
Now, I think I have a small follow-up question. If
Sure.
today we put a student to do PhD, what topic would you point him towards?
It's good. That's a good question. I am not academic person, despite I'm in a way or another involved in like King Saud University here and like consultant for some other universities and institutes. So actually, the best is to have a PhD thesis or a PhD project for a purpose. So I am happy when I see that is a PhD project, it become turned into a product which can help people. There is a lot of development going on. There is sensors, there is self-vestibular rehabilitation tools that have been developed, and many of these just it have been a PhD project. So if the PhD work and project, it change it into a project, into a product to help in diagnosis, to help in the management of patients, this is something I really admire. This is something it can be thinking about PhD project or a PhD topic. One else, good PhD project to validate a protocol, which can do some changes in the practice. And this is something also could be very valuable, or to address a major common problems, especially if it's related to the community. I don't like this kind of project that it has to be made as a papers, both as a paper, someone got a degree or a credit, but actually it has no impact in the real world. This is waste of the effort and waste of the resources. So either it turn into a project, into a product, diagnostic or rehabilitative or therapeutic, it validate protocols, it better address or understand the disease. Because what's going on, we don't know much about most of the diseases. Any project which addressing a disease, trying to better understand, which really could change our understanding, because the way we understand diseases is the way we can really improve our management of these diseases. So this kind of topics related, and it's also wise if you have like BPV, I can say it's a public problem. All falls related injury, it's related to BPV in some way. It has a major impact, and it's something which can be like, for example, diagnostic screening tool for the public. We will screen all the country about the BPV. We'll just use the 5 positional questions in the business handicap inventory. We do telephone calls, we do, then we do that. Just you can change, you can solve a public problem by through a PhD project, because it need a dedication and it need time. It need a lot of collecting data, a lot of analyzing data. So having a purpose other than getting a university degree. Getting a university degree is not a honorable purpose itself, but what this kind of like PhD, how it helped the people worldwide, regionally, locally, nationally, whatever, how it really help. It should have really an extra purpose. What would be its benefits to the current practice and to the humanity.
Perfect. Dr. We cannot thank you enough, Professor Alfargal. I think.
No, it's always my pleasure, my dear friend. And congratulations, Ms. Chandra. I'm very happy of you. I postponed my breaking my fasting to be with you because you deserve. I observed your learning journey. You can inspire many colleagues. That is, if you are determined, persistent, finally, you will get your seat. And yes, everyone who follows his passion, finally he got his seat, he got the recognition. And thank you.
Thank you, sir.
Thank you very much. And from all of us here in India, we wish you Ramadan Kareem again and hope that your prayers are answered and your journey is comfortable. We look forward to more interactions like this. We look forward to your physical presence with us.
Inshallah, my dear friend. All the best and thanks for the audience. Thank you very much.
Thank you very much. Thank you, everybody, for your patient listening. We far exceeded time and we didn't feel the time go by. So I think that's a proof of Einstein's theory of relativity. Thank you very much.
Thank you, all of you.